Our next speaker is Dr. Joan Bathon, who is a person that really needs no introduction. And she's going to talk about cardiovascular risk and RA, improving prediction.
With them, right? So I'm going to talk about cardiovascular risk. Rheumatoid arthritis has always been my area of interest in research, and cardiovascular complications I got interested in back in around 2002, 2003. So this topic, which I gave myself, is another one that has no data in RA in terms of how do we predict who's going to get events. In terms of at least building an algorithm of prediction like a Framingham equivalent. But we're going to try to muddle our way through it. And what I would like to do is talk a little bit about composite indices, and then what does imaging data add to that, and what might biomarkers add to that. A lot of the things that I'll talk about have to do with the general population, are based on data from the general population. So we know already that RA patients die a few years earlier, 5 to 10 years earlier than patients without RA, at least in the past. And that's shown nicely here in this study where women without RA are shown in pink. This is survival decreasing over time, and the RA women in blue, and you see a substantial difference in mortality rates. And then men without RA in green, and then men with RA in yellow. And we know now that the major cause of excess deaths in RA is due to cardiovascular disease. And we know from the Mayo Clinic that RA patients with cardiovascular events present a little bit differently. They're more likely to have silent MIs, as shown here in this top of this graph. These are data from the Mayo Clinics, and these are RA patients in the dark line and control patients in the light. So more silent MIs, and conversely less angina. And they're also more likely to have sudden death than patients without RA. And when they do have acute coronary syndrome, the mortality is much worse in RA patients compared to those without RA. So that's a statement of the problem. And we know now from the data that's emerged from multiple groups that it looks like both inflammation and conventional risk factors are contributing to the risk of cardiovascular events in RA. So it's important that we screen for and treat conventional risk factors in addition to tight control of RA disease activity, even though we haven't developed a prediction model yet. So I don't need to remind you, but I will anyway. Traditional risk factors are shown here. We all know these and look for them, hopefully, in our patients. And we know that one of the most utilized risk predictors, at least for coronary events, is the Framingham 10 risk score. And this is based on age, gender, total cholesterol, HDL, smoking, blood pressure, whether they're on medication, and then you calculate the risk score. And this can guide us in using statins. Now, what's not on this list? Diabetes is not on this list because that automatically puts somebody into a high-risk category. And there are a few other things that aren't on here that we know are risk factors, like family history and so forth. But this is a good guideline, and one which has high predictive value for identifying people who might develop cardiovascular events down the road. And so the management of these risk factors is periodically updated by this group, NCEP, ATP, and I don't remember what every one of those initials stands for, but blood pressure control is important, especially in diabetics where a more stringent level is required. Healthy eating, aspirin if there's moderate to high risk. LDL cholesterol level that you want to achieve depends on the level of risk, so less than 100 if you're high risk, less than 130 if you're moderate risk, and then less than 160 if you're low risk. Obviously, physical activity, controlling weight are important, and then controlling fasting glucose. Nothing that you don't know already. So these are data from I forget the Framingham heart study, and this is an interesting analysis in 50-year-olds, which is kind of the general age of our patients that we see, at least in all the clinical trials. Common time of onset of RA. This is non-RA patients, though, from the Framingham study, looking at the predictive power of major risk factors versus elevated versus slightly elevated versus optimized risk factors, and then the number. So in blue, here's men on the left and women on the right. The blue line is patients who had greater than 2 major risk factors defined by a high total cholesterol, high blood pressure, smoking, or diabetes. And you see that over the ages of 50 to 90, the risks the risk increases for having cardiovascular events, such that by the time patients is 90, about 60% of them are at risk for cardiovascular event. And as you have fewer or less severe elevations of these risk factors, the risk goes down, so there's a pretty nice dose response here. Now, women are interesting because you see even at the 90-year range, the risk as measured by these risk factors is considerably less than in men, even though a lot of women in their 90s have events. These risk factors don't predict as well for future events as in men. And this is important to know because this is where the majority of our patients are. They're women, and they tend to at least start out at the 40, 50-year-old range with their disease. So here's women again from the Framingham study, and it looks at categories of women by decade up to the age of 80. And just looking at, once patients reach 80, they have a high likelihood of having a cardiovascular event. But even if you could look at the 60 to 69-year-old range, very few of them meet the 10 to 20% Framingham risk or the 20%, and only a few more at the 70 to 79 level. So the theme here is that the Framingham is good for men, it's less good for women, and for women with RA, it might be even less adequate. Well, what do we know about risk factors, conventional risk factors in patients with rheumatoid arthritis? We used to think they weren't different from controls because the data weren't as carefully obtained. There were retrospective studies or there were epidemiological studies in which risk factors weren't as carefully looked at, and so they seemed to be pretty equal in the early studies. But as the studies have accumulated, it's pretty clear that the risk of hypertension is higher, the prevalence of hypertension is higher. We know for sure that RA patients smoke more commonly than non-RA patients, and that's a big risk factor for developing RA as well as for cardiovascular disease. We're learning that there's more dyslipidemia, so even if the levels go down, there's an imbalance in the good to bad cholesterol. Obesity looks like it's equivalent when you measure BMI, but I'm going to come back to this issue. If you look at total fat, it's a different story. Diabetes is equivalent, but insulin resistance is increased. And this insulin resistance is an independent risk factor for cardiovascular events. And then hyperhomocystinemia is either equivalent or increased. So, regardless of their disease activity, it seems like our patients have more conventional risk to start with, so we better pay attention to that. Now, I'm going to come back to this issue of BMI, because if you look at all the clinical trials, and the companies are starting to report BMI, you didn't see that much in the early studies, and it was hard to get information about weight. But in most of the studies, BMIs don't look different. There are no controls without RA in these studies, but if you compare the BMIs with studies that have similar age and gender in non-RA kinds of studies, they're not quite different. And we've looked at this in our own cohort. When I was at Hopkins, we had a cohort that you'll hear about a little bit more of 200 people that we followed for cardiovascular disease, and their BMIs weren't really different from non-RA controls either. But BMI doesn't tell you the whole story because there are depots of fat that are much more risky in terms of cardiovascular outcomes than others. And abdominal fat is much bigger risk for cardiovascular disease than peripheral fat, for example. But not even all abdominal fat is the same, and as I'm sure you know, visceral fat, the fat inside the peritoneum, is the depot that seems to convey the highest risk for cardiovascular events. So here's an example of two patients. This patient might have a higher waist circumference, but has less fat, and that's depicted here by the white material in this scan, whereas the diabetic, who might have a smaller abdominal circumference, has markedly increased in visceral fat, and this may contribute to his or her cardiovascular risk. So the question comes up is, do RA patients differ in terms of their fat? How come this doesn't happen to anybody else but me? So it turns out, as you probably know, that men have more visceral fat than women. You guys have your fat in a different spot than we women, but when you measure the waist circumference, men tend to have higher waist circumference than women, but the important thing is that there's more visceral fat in men in general than in women. Women tend to have more sub-Q fat. So we started to look at this early on, first by DEXA scan. We're used to getting bone density by DEXA scan, but you can actually measure total fat and total lean mass, which is an approximation of muscle